speak about tubal patency test, which one to choose. So, well, as far as tubal patency is concerned, traditionally, we all have used HSG as a gold standard since years, right, to test the tubal patency. But now there has been an ocean of evolution even in this tubal patency test. And therefore, we have many other options available. So unless and until we know about the other options available to us, we will not go for it. So today, what I'm going to do is try and put in front of you all the options and the merits and the pitfalls of each, so that we can choose a particular important test for a particular patient. So the options, different options available are HSG, SSG, that is sonosalpingography, HYCOSI, which is hysterosalpingo contrast sonography, and laparoscopy. So various references that are available to us today are, these are all the recent references of 2021, mainly the ASRM, American Society for Reproductive Medicine, and very recent studies. And also we have some Indian authors like Dr. Sonal Panchal and Dr. Sharda Jain, who have also done a good work on newer tubal patency tests, especially the sonosalpingography and the HYCOSI. So, before we learn about the tubal patency test, I think we must rebrush our anatomy that we all learned during our PG days, right? So as far as the anatomy of fallopian tube is concerned, we know that it starts as isthmus, then the ampulla, and then the infundibulum and the fimbria towards the ovary, right? These are the parts of tube. Now, it's not just the anatomy which is important. The functions of fallopian tube are also important. When the follicle ruptures and releases ovum, the fimbrial end of the tube proceeds to cover the ovulation site, and the ciliary movement in the tubal lumen creates negative pressure, sucks the ovum from the follicle into the tubal lumen, and the fertilization occurs in the tube, and then the embryo advances towards uterine cavity for implantation. This basic fact we all know about it. So basically, if we look, fallopian tube is the first home for all of us, right? Our journey began in fallopian tube. So the tubes are not just tubular portals, but are motile structures and have peristalsis. So the four important aspects for preservation of fertility are tubal patency, tubal peristalsis, fimbrial function, and tubo-ovarian relationship. The evaluation of fallopian tubes is an essential part of evaluation of subfertility, because we know that 25 to 35% of subfertile patients have tubal pathology as a cause of subfertility. So what are the various pathologies which can hamper the fertility? It can be tubal block, stenosis, dilatation, impaired peristalsis function, could be due to PID or endometriosis or previous pelvic surgery or pelvic tuberculosis. So accurate evaluation of fallopian tube is crucial, because an incorrect diagnosis may result in unnecessary tubal reconstructive surgery or IVF, that is in vitro fertilization. So now, what is an ideal test for tubal patency? It is like an ideal man or ideal woman. Do we get? With all the qualities as mentioned here in ideal man, or all qualities mentioned here in ideal woman, besides being a beautiful, all the qualities we expect in an ideal man or woman. But is it possible? Similarly, an ideal test for tubal evaluation should correctly identify all women with tubal disease, should be easily available, minimal false negative test results, should be cost effective, should be well tolerated by the patient, and should not have any complication. However, such an ideal investigation is yet to be found, and therefore various tests have been tried to assess tubal status. So which are they? That's HSG, that is hysterosalpingogram, that we have been traditionally doing, sonosalpingography, SSG, hysterosalpingo contrast sonography or HYCOSI, and we have a detailed talk on HYCOSI by a very experienced radiologist, Dr. Rao, after my talk. So I'll not throw much light on HICOSI. And the fourth one is laparoscopy and chromoperturbation, LAP-NDI, which also we are using very, very frequently. So, well, friends, I'll be using all these short forms because it's difficult to pronounce these terminologies repeatedly in my talk. So HSG, SSG, HICOSI, and LAP-NDI, that is what I'm going to use during my talk. Now, the timing, the right timing of procedure is extremely important, and that is a mid-proliferative phase for any tubal patency test. That is day 6 to 10 in a typical 28-day cycle after menstruation stops, but before ovulation occurs, to reduce the risk of disturbing any early pregnancy, because ultimately we are working towards fertility of a woman. So we do not want to disturb pregnancy if at all patient has already conceived. Again, the basic principle in medicine is first do no harm. So what are the contraindications of tubal patency test? Whenever there is an active infection in the form of either vaginitis, cervicitis, PID, we should not be going for tubal patency test. Give a good course of antibiotic, treat the infection first, and then go ahead with your tubal patency test. Now, hysterosalpingogram is a traditional radiologic procedure to investigate uterine cavity and patency of the fallopian tubes. So it's a domain of radiologists, but we have been sending our patients to radiologists for HSG or hysterosalpingography. Right here, the dye is injected, and the X-ray is taken, and as we can see, these are the patent fallopian tubes, and here there is a proximal block in the tube which can be seen on X-ray. Now, the benefits of HSG are it is widely available, it can be performed in outpatient setting, it is safe, not much expensive, the site of tubal block can be identified because of contrast medium, it also enables concurrent assessment of the uterine cavity, some of the polyps, fibroids can be made out through HSG. So that's the benefit. And what are the limitations? It's very painful. We all know every patient of ours who goes for HSG always comes back complaining that it was very, very painful. But because it's very short procedures, anesthesia is not used for this. It has a limited role in assessing pelvic pathology. It will tell us about the tubes, but nothing about the pelvic pathology. Unable to detect abnormalities in the ovaries and myometrium like endometriotic cyst or adenomyosis, which also can lead to subfertility. There is an exposure to ionizing radiation and a small risk of iodine allergy. We have heard of a very rare case, though it occurs very rarely. We have heard a case of rare allergy to iodine where the patient has even died on table. So yes, there are some risks associated with it. Now, this is something very interesting, and I'm sure most of us have, experienced it, or we have seen that after HSG test, within 3 to 6, a patient conceives. So there is a concept known as tubal flushing or tubal go, where the studies have shown that there is up to 30% increased pregnancy rates for the first 3 to 6 months after HSG, and it's presumed that the dye itself flushes out the debris. So I tried to find out the scientific basis of it, and here it is. There is a Cochrane study. This is recent October 2020 study, Cochrane study, and the evidences suggest that compared to no treatment, tubal flushing with oil-soluble contrast medium may increase the chance of live birth and clinical pregnancy. However, the adverse events, especially long-term adverse events, are poorly reported across studies. Now going to our ultrasound technique. That was a radiologic procedure, right? So for us obstetrician, sonosalpingography or sonohysterosalpingography or saline infusion sonography. These are the different names for the same procedure, which is an ultrasound guided procedure, and it uses transvaginal sonography to confirm tubal patency by visualizing turbulence near the femoral end as we inject the saline through the catheter placed within the uterus. So I'll go into the details of this particular procedure. So why do we need to inject the saline? Well, basically the normal and healthy fallopian tubes are not possible to visualize on TVS, right? And the reason is the diameter of fallopian tube is very small, less than 4 millimeters. It has serpiginous course. It is there in between all intestines. When we are doing TVS, we can see all intestinal loops, but not the tube. There is no tissue fluid interface when the tubes are normal, and that's the reason normally we cannot see normal tubes on transvaginal sonography. So what is the basic principle of SSG or sonosalpingography? Well, this tissue fluid interface is created artificially by introducing saline in the uterine cavity and fallopian tubes and scanning simultaneously. So what do? Oral or injectable analgesic is given 30 minutes before the procedure, either ibuprofen or diclofenac injection or buscopan. I personally prefer buscopan. Empty the bladder. Strict asepsis is essential. We should not add any infection to this patient who's come for subfertility. A detailed transvaginal ultrasound is done to assess position of pelvic organs to rule out any other pathology. We may come in the way of procedure or any free fluid which is already existing in the pelvis also checked for. Foley's catheter, either 6 to 8 French, which is a special catheter or a special catheter is introduced and the bulb is inflated. The capacity of this is around 3 ml. So you can inject around 1.5 to 2 ml and the saline is injected through the catheter slowly and the scanning is done simultaneously. Well, friends, I have some videos and images which I'm going to show after this procedure is narrated. When the uterine cavity is filled with the saline, it distends and any endometrial pathology can be demonstrated and diagnosed. The spill of saline from the femoral end is seen as a shower or turbulence at the femoral end or fluid flow surrounding the ovary and collection in pouch of Douglas on B mode scanning. An absence of spill at the end of procedure may indicate blockage. Now, one important point about this is it is not always possible to document the spill from the femoral end of both the tubes. So I have done the procedure in which when I inject, I can see the flow, the spill from one end, and when I go to the other ovary, I may, if I inject again, I may see the spill again, but sometimes to document both the spills may not be possible because we have to look at one and then one after the other two. In such cases, fluid accumulation in the pouch of Douglas confirms patency of at least one fallopian tube. Now, in patients with bilateral block, distension of uterine cavity is going to cause severe pain and no spill is observed. Now, there have been some modification in this SSG to improve its diagnostic accuracy, then that is using color Doppler, combining air and cell line, and 3D sonography. Now, adding color increases the efficiency and accuracy of, because we know the movement of fluid will give you red and blue signals, which we'll see in the video, which I'm going to show now. So, this is the video clip which is showing the catheter can be seen. Is my arrow seen? Can you see my cursor?
Yes, ma'am. Yes.
Okay. So the bulb is seen in the uterine cavity, and as I'm injecting the normal saline, you can see the uterine cavity beautifully being delineated here as the saline enters the uterine cavity through the catheter. Here it goes, right? So this is how we can beautifully see the uterine cavity as we inject the saline. Now this is with the help of color Doppler. So again, my cursor is at the point where you will see a, yes, here you can see a lot of colors coming up as I inject the fluid, and that shows the patency of this particular tube because the fluid is coming out from the fimbria, which is giving all these signals, color signals, right? Now, here I was fortunate to have good, as I said here, we try to create this tube fluid interface. So that is beautifully seen here. We can see this is the ovary and this is the tube which is floating in the fluid which has been injected. The fimbria also can be clearly seen floating in the fluid. So there is no perifimbrial adhesion and the tube is quite free floating in the fluid. So that gives tells us gives us information that this tube is healthy and normal with free floating fimbria. So every time we may not get this picture, but very likely we can get this. Now these are the images. Why? Because we always document with the images pre-procedure and post-procedure. So pre-procedure, as we can see, there is no fluid in pouch of Douglas. Well, we have to empty the bladder and there is no free fluid in the pouch of Douglas. Whereas at the end of procedure, as you can see here in the pouch of Douglas, there is a free fluid behind the uterus. So this will documentation will tell us that at least one of the two two tubes is patent. Now this is, I'm trying to show an abnormal tube. This is the uterus. And as you can see, what is coming up here, the evolution structure is a dilated tube. As you can see, yes, there it is, right? So entire hydrosalpinx can be seen even without color. And when we add the color, again, the same tube will be filled with fluid, and that will be seen as this color signals, but there is no spill. You can just see the fluid inside the dilated abnormal tube, but there is no spill here, right? So this is the image of this hydrosalpinx, which we can see through sonosalpingography. Now, what are the side effects? Well, when we try and inject any fluid inside, it's going to distend the uterus, and therefore nausea and vomiting, pain, cramps in the lower abdomen, bleeding in some cases. Vasovagal syncope is very, very rare. We always give atropine pre-procedure. Risk of pelvic infection and peritonitis. Again, if we are very careful, we've chosen the patient well, it's not going to cause any infection. Failure to perform or complete the procedure is again very, very rare as compared to HSG. So the benefits are, it's an office procedure, low technology, low cost, no radiation exposure as compared to HSG. Vagal effects are very mild and well tolerated, provides concurrent accurate assessment of the endometrium and endometrial cavity. We could see in the video that the uterine cavity is seen very well with this. Gives idea about tubo-ovarian relationship and fimbria also, which we saw in the video, and allows simultaneous ultrasound evaluation of the pelvis. The limitations, site of tubal block can't be identified, right? We see the spill through the fimbria and the fluid collecting outside in the pouch of the glass, but we can't pinpoint the site of tubal block if the tube is blocked. Intratubal mucosal pathology is not identified. Visualization of the tube is not optimal, may not differentiate between unilateral and bilateral patency. Mobility of tube may not always be assessed. So the accuracy of saline SSG is comparable to office hysteroscopy in detecting polyps, fibroid, and focal endometrial thickening, which is the benefit of SSG. Now we go on to the other procedure, which is hysterosalpingo contrast sonography, and we have entire talk by Dr. Rao on this. So I'm not going into what all contrast media use. Just I would like to tell you that there is a suspension of microbubbles, and this passage of hyperechoic contrast agent through the tubal lumen delineates it, and biggest advantage is it locates the site of block because the contrast media is going through the tube. I'm not going to go into the details of contrast media, and I'm sure Dr. Rao has a very particular contrast media that is being used by him, and I'm not going to reveal that. Let's have it as a suspense, and he'll reveal his own secrets as to which media he's using. And the sensitivity of HYCOS is around 93% with specificity of 89%, which is quite good. And these are some of images of HYCOS. The benefits, again, office procedure, minimally invasive, more efficient than sonosalpingography, and the site of tubal block can be made out through this. Limitations, it needs higher-end ultrasonography machine, needs higher expertise, cost is higher than sonosalpingography. We know 2D and 3D higher-end machines may not be available in the periphery. 70% of our India is in rural area, right? So there HSG is more useful because we don't have higher-end machines, nor do we have higher-end expertise. So these are some of the limitations, and of course cost of contrast media. Laparoscopy and chromoperturbation, or lap and dye, is gold standard investigation for tubal assessment, because we all have done this, we all have seen this, as the methylene blue is injected through the uterus, and we can see it coming out from the tubes, and very well we can document that the tubes are patent or not. Benefits: allows direct inspection of fallopian tubes, assessment of pelvic pathology like endometriosis and adhesions, can be used to even correct, not just diagnose, but correct tubal factors like fimbrial phimosis and peritubal adhesions, which may not be identified with less invasive methods like HSG and HYCOS. It enables hysteroscopy and therapeutic procedures like tubal surgery or hysteroscopic tubal cannulation. So all these additional things are possible with laparoscopy, which is not possible with other methods. But everything has its pitfalls also. So the limitations are the assessment of internal architecture of the tube is not permitted, and it's not always possible to identify the site of tubal occlusion. It is more invasive. We know it needs anesthesia. It's a surgery. So cost is also more, needs anesthesia, and therefore carries the risk of anesthesia as well as surgical morbidity and mortality. So no one method has all pluses. Every method has few pluses, few minuses. The ASRM guidelines say that laparoscopy is not recommended as a routine method for assessing tubal patency. However, if laparoscopy is indicated for some other reason for this infertile patient, then chromoperturbation is always done to look at the tubal patency. RCOG recommends that where appropriate expertise is available, screening for tubal occlusion using this is a mistake. Tubal patency assessment using Hysterosalpingogram should be considered for women who are not known to have comorbidities like pelvic inflammatory diseases, previous ectopic pregnancy, or endometriosis. However, if you suspect some of these pelvic pathologies, then please mute everybody. Viraj, please mute everybody. However, if you suspect any pelvic pathology, then lap and dye is a standard test which should be chosen for tubal patency. Now, hysteroscope. Do you have any role of hysteroscope in tubal patency? Can we have everybody muted? I can see some noise. Okay, thank you.
I think Dr. Motwani, sir, please mute yourself.
Okay, thank you.
Yeah, thank you.
So I found this very interesting article, which is a very recent September 21 article, novel use of hysteroscope in the assessment of tubal patency. So how they use the hysteroscope? Where in HSG, the cannulation with a standard Leach-Wilkinson cannula through the cervical canal was difficult, and tubal patency test showed tubal block. What they did was they injected the methylene blue dye through the inlet of hysteroscope and did chromoperturbation. And this shows positive tubal patency test. And this basically bypasses cervical factor in such cases where there is very tight internal os and reduces false negative results for tubal patency. Though it is very good, it needs a setup where you have to have a radiology setup as well as hysteroscopy setup together, then only this can be used. Now, just to complete the test to assess tubal pathology, this was an interesting test which is not used widely in India, but is being used in USA, that is Chlamydia antibody test, and detection of antibodies to Chlamydia trachomatis is associated with tubal pathology, but it lacks the clinical utility to predict tubal patency. However, it has a higher negative predictive value, almost 80 to 90%, and therefore a negative Chlamydia antibody test suggests the absence of tubal disease, but if it is positive, you need further evaluation to determine tubal patency. Now let's compare all the methods that I've already narrated. So what is the sensitivity to pick up tubal block? HSG 75 to 80%, SSG or saline sonography 80 to 85%, Hysterosalpingogram with contrast medium 93%, lap and dye 100%. Let's look at the comparison between two methods. Agreement with HSG, which is traditional. SSG comes in agreement with SSG to the tune of 94%, Hysterosalpingogram to the tune of 100%. Agreement with lap and dye, which is gold standard, HSG only 75%, whereas Doppler SSG 80 to 90%, Hysterosalpingogram 91%. So you can see how one method is better over other. Now comes our million-dollar question, which with I started. Which test to choose for tubal patency? So obviously, when there are likely to be some comorbidities or pelvic pathology, then yes, of course, we would go ahead and directly do a lap and dye. So suppose you are suspecting endometriosis, or on ultrasonography you find an endometriotic cyst, or you are suspecting PID something, then of course you will go for lap and dye and check for patency for tubes. But if there are no comorbidities like 2 to 3 years of infertility and no PID, no suspicion of any pelvic pathology, then again we are back to which test to choose, HSG, SSG or Hysterosalpingogram. We have again 3 options. So as Warren Buffett has mentioned, it is better to be approximately right than precisely wrong. So where available, Hysterosalpingogram with contrast media is a good option. Where it is not available, our HSG and SSG are good options. And once you offer this test to patients, ultimately we should be able to decide what to do on these patients of infertility, right? So decision making after this tubal patency test, so if you have done your HSG or SSG, if you find that there is correctable tubal pathology, fimbrial block is there, then you can deal with it through laparoscopy. If it is not correctable, like bilateral tubal block, you are sure it's proximal bilateral tubal block, not correctable, of course, we have to offer IVF to the patient. But when there is uncertainty on HSG, you are not very happy with the film, you are not sure whether the dye has come out, you are not very sure whether there is real tubal block or not, on saline sonography, you are not very sure whether, both the tubes are patent or not. In such cases, you should go for the gold standard, and that is lap and dye, that is laparoscopy and chromoperturbation. What are the recommendations by ASRM? All available methods for evaluation of tubal factors have technical limitations that must be considered when one technique yields abnormal result, and further evaluation with the second complementary method is prudent whenever you are uncertain of the tubal patency. So the carry-home message is tubal evaluation is essential in subfertile patients. HSG has been traditional and widely available method, and we can do it on outpatient setting. So it is still a good tool in low risk setting. Where need be, supplement it with lap and dye. And SSG or contrast hypoxia can be considered as first line tool when there is low risk patient, you have availability of it, and there is no known reproductive comorbidities, and provided you have higher end ultrasound machine as well as appropriate expertise for the same. Lap and dye is gold standard, not for all, but where you suspect some reproductive comorbidity, then you should subject these patients to laparoscopy, because we can not only diagnose, but we can also deal with some of the pathologies at the same time. So with this, I would like to end my talk, and I always like to tell this, that as chairperson of FOGSI Imaging Science Committee, it is my dream to see every obstetrician and gynecologist a sono obstetrician and gynecologist. If I can learn, I think everybody can learn, and I would continue to work for the same during my tenure of 3 years of chairpersonship. So thank you so much, everybody, for patient hearing. Thank you.